you have an obligation for school soon or no?
Sorry, can you repeat that?
Yeah, do you have somewhere to go after this? I'm just trying to decide which one of us should go.
No, I'm gonna be here for the whole time.
Okay, so I guess I'll introduce both of you guys, and Tanisha, maybe you can go first. So I'm Jane Kurtzman, for those of you who don't know me that are on the call. I think a couple other people just logged in. I'm the second year reconstructive urology fellow at the University of Utah here, and I've been working with Tanisha as well as Dr. Zoë Cohen. Tanisha, I'm sorry, how do I pronounce your last name?
Martheswaran.
Martheswaran, and Tanisha is a now second year medical student at Johns Hopkins University. She is from Utah originally, and she spent the summer here doing some work with the Center for Global Surgery and Dr. DeVries, as well as myself. I believe that she's going to be giving a separate presentation at a later time, probably about the work she's been doing with Dr. DeVries, because she's out of the country right now. But Tanisha is going to be presenting on the research project we worked on together over the summer. And then we also have Dr. Zoë Cohen, who's here. And Dr. Cohen is a fourth year resident at Columbia in urology over in New York. And this year we are piloting in urology and with the Center for Global Surgery, a global urology resident research scholar. And so Zoe has a dedicated year of research at Columbia, and she's dedicated about 50% of her time to working on global urology projects. So she's going to be talking about a project that we have in the works, and we'd love feedback both on Tanisha's project as well as Zoe's project, Dr. Cohen's project, which is soon to be underway. So thanks for being here. Tanisha, you can take it away, and then Zoe will go next.
Okay, sure. I can share my screen if that's most helpful. I didn't know if Liz had my presentation, but I'll share it. Oh. No, I don't. Maybe you can see this. Okay. Present. Let's wait, no. All right. Okay, like this. Okay, can everybody see this?
Yes, but it's your presenter view or slides. So you might use slideshow mode.
Oh.
Try that.
Oh no, wait. I don't know if that's what I wanted to do. That's strange. Okay, wait. Just normal slideshow then?
Yeah, I think.
Wait.
It just has the.
Is it still presenter view?
Mm-hmm.
If you wanted to not be in presenter view, Tanisha, go back to where you were. Is that good?
Is this better?
Yes.
This is fine. This is the center.
Great. I figured out. I had to click swap displays. Sorry. Okay. All right. So good afternoon, everybody. My name is Tanisha. I am a second year med student at Hopkins. I worked with Dr. Kurtzman this summer looking at a project that assesses global disparities in urological research. And we did a meta-analysis of low and middle income country representation in urology journals for over the last 10 years. So as a background, research plays a very critical role in driving academic dialogue and also fostering advancements in surgical and healthcare practices. However, there are certain areas that remain very underexplored, and notably that of low and middle income countries, and especially within urological journals. However, it's really important that we include LMICs in the overall conversation about research because it ensures that diverse perspectives are heard, especially from regions that have really high healthcare burdens. And without this representation, we can risk overlooking context-specific challenges and solutions that are necessary for improving urological care worldwide. Okay. So there are several studies that have already shown this underrepresentation of low and middle income countries within research. So this includes the global health space. So it has been shown that there's low representation of LMIC authors within global health publications. They're more likely to publish in open access biomedical journals, which can reflect cost barriers that they might face or general awareness and accessibility. They're also underrepresented in global surgery research with only about 23% of publications involving LMIC researchers. And this was like within broad global surgery. And then other specialties like orthopedics have found similar results. And to put this in context, there are fewer than 0.5 urologists per 100,000 people in many LMICs, compared to about 5.7 in high-income countries. So this highlights a pretty significant gap, not only in the workforce, but also in the research that should be driving policy and care improvements in these regions. And so we wanted to explore these gaps and bring attention to disparities and improve outreach and the impact of health research on a global scale. Okay. So our main objectives were to look at income-based urology publication representation and trends over time. So we looked at LMIC representation of urology publications by income categories from 2013 to 2023, and then compare this to the overall global populations. We wanted to look at income-based categories for first authorship affiliation and then trends. We wanted to look at disparities amongst different journals. So we looked at, a broad range of journals and looked at their representation of LMIC publication per journal. And then we also wanted to look at country and language representation in urology research. So we mapped it by country in the categories and then also languages. So our methodology was to first classify countries by income status. So we looked at the World Bank data over the last 10 years and looked at the most common income status for each country. So there were 4 different categories. So upper middle income, middle income, middle income, low income. That should just say low income, and then high income countries. So we found over 100 urology journals. So I looked at a couple of different sources, Cymego, research.com, just for the active list of a broad range of urology journals. So there were obviously, the really big ones, and then anything that may publish urology research. And then I got the ISSNs for each journal. And then I utilized Scopus to get all the publications over the last 10 years from about 117 journals. And we had a pretty strong exclusion criteria. Whoops. I'll go back. So we started with about 144,000 papers, and I'll talk about exclusion in a little bit. But the analyses were done using Python. So I wrote code to look at, the proportion of affiliated publications by the income category. And the affiliation is defined as whether the country is included in the title or abstract, or if any author of that paper is affiliated with that country. And then I looked at trends over time, so over the last 10 years, so whether there was any increase or decrease in representation for each income category. I looked at first authorship, as that's quite a relative indicator in low and middle income countries. And then I looked at top journals by publication count and also by proportion of low and middle income country representation, and then country and language representation. So we started with about 144,000 articles. We excluded duplicates, articles that didn't have authors or titles, and anything that didn't have author affiliations, or if there was nothing identifiable in the text box. And then we ended up with about 128,949 articles. So we had a lot of data. So here are the results. So we found that the first pie chart on the left shows the proportion of all urology publications from 2013 to 2023. We found that almost 71.7% of publications came from high-income countries, whereas 21.1% came from upper middle income, 6.3% represented middle income, and then just 0.9% represented publications from low-income countries. And the pie chart on the right shows its comparative population proportions based on income status. So to put things into context, high-income countries comprise 16% of the world population, but contribute 72% of the research. 40% of the world's population comes from middle-income countries, yet just 6% of research comes from the same countries. So this is the slide that has the main statement. So 84% of world's population lives in low and middle income countries, but they contribute just 28% of the research. So these highlight already some pretty stark disparities. And this is not out of the ordinary. Like, this is something that we would have predicted, but it just puts it into context to see just how great the differences are. So here's a chart that shows the trends over time. So from 2013 to 2023. So the solid line shows the affiliation percentage, so whether any author was affiliated with the country or if the country was in the title or abstract. And then the dashed lines are the first authorship from these countries over time. So for upper middle income countries, the affiliation percentage increased from about 16% to 28%. So that's actually a pretty significant increase. First authorship went up from about 13% to 24%. So that's a positive trend. However, for low-income countries and middle-income countries, the increase was very minute. For middle-income countries, it went from about 6.3% to 7.9%. And then in low-income countries, the affiliation percentage increased just from 0.8% to 1%. And then authorship was even lower, from 0.3% to 0.5%. So it's very, very low. And although it is positive for upper middle income countries, it still highlights a really pressing issue for middle income and low income countries, that they aren't able to increase representation. And there are barriers probably against them being able to do so. So, and here's a world map snapshot. So this shows the top 3 countries from each income category based on their affiliation, based on their first authorship affiliation. So the purple is the high income countries. So the top 3 countries with the most first author publications were the United States, Japan, and then Italy. So those were the top 3 high income. And then for upper middle income, we had China, Turkey, and Iran. And then middle income countries in blue, the top countries were India, Egypt, and Indonesia. And then for low income countries, Niger, Mali, and Ethiopia. And you can just see from this how vast the difference is in publication. So the United States published over 37,000 articles, whereas number 1 in low income, Niger was just 280, and then Ethiopia was just 52, and Mali was 55. So this is a pretty crazy graphic, actually. So here, next we looked at urology journals by the greatest number of publications. So this is just shows the top journals by publication count. So no other indicators. So Journal of Urology, European Journal, World Journal of Urology, and then BJU were the top 5 in terms of publication count, and then 6 through 10 are on the right. So then what we did with these journals was look at their percentage of overall low and middle income country representation, and then look at low income country representation specifically. So in this chart here on the left, you can see the journals listed and then their percentage of LMIC representation. So Journal of Urology was about 12.5% from low and middle income countries. And so there was quite a wide range, but still quite low, except international urology and nephrology was about 62%. But then I was curious and I looked into that, and 55% of that was from upper middle income countries, and then the rest were from low and middle income countries. So which makes sense for a lot of these journals. The majority of what you see here is from upper middle income countries, and very small percentage are from low income or middle income, as you can see from this column here. It's all very, very low. And then I looked at language of the original document too. So the top 3 languages were English, Russian, and Japanese, but obviously English predominates with over 130,000 articles. So this may reflect some sort of language barrier that could be at play, but I thought it was interesting to look at the wide representation of languages that exist amongst the publications. So in summary, LMICs contributed only 28.3% of all urology publications, despite being over 84% of the global population. Low-income countries also contributed to just 0.9% of publications, and it increased just marginally from 0.8% to 1%, and same with middle-income countries. First author disparities, only 25% of first authors were from LMICs, with just 0.4% from low-income countries, which reflects limited representation and research leadership from these regions. And there was also a wide variety of representation within journals, range from about 12% to 62%, yet most were from upper middle income countries. Highlights again slow progress for low income countries over time, and then potential language barriers that may exist that may limit participation from non-English speaking LMICs. So to highlight why this is important, so these findings do underscore a need for greater inclusivity and diverse discourse within urological research. And it's important that we increase visibility because this can foster a more equitable global research environment within urology and ultimately can improve surgical outcomes and health practices in resource-limited settings. So here are some ideas that we had for how this work can be furthered and hopefully applied on a greater scale. So we could create space for LMIC research within top journals, whether that be, an additional section or just creating more accessibility and awareness for how to publish, and making room for more open discourse, reducing barriers to publishing and access through fee waivers, inclusive decision-making within executive roles. So what I mean by that is I went back and looked at the editorial boards for a lot of those urology journals, even the ones that were international, and the vast majority, if not all, were from high-income countries. So that's worth noting that even within their executive leadership, or those who are making the decisions about who is getting published, there's not much representation in those roles. So it can be helpful to have more diversity within who is leading these journals. And it's very important to value contextual relevance. So I think a lot of pushback from this may be that, the quality or the standard of research from low and middle income countries may not be what is normally published with high income country journals. Like the work that's being done in LMICs may not be relevant to what's being done in the United States, but that is the issue at heart here, is kind of dismissing that notion and understanding that the work that is done in LMICs may help another LMIC just because it's not relevant to us. So really understanding how to encourage collaboration outside of our own little, bubble, including them in conferences, language support and translation services, reducing bias in manuscript review, providing mentorship and advocacy, and allocating additional funding and grant support may also help increase representation. It's also worth noting that, of course, everything that you've seen in the presentation today may be due to the fact that there are just fewer urologists working in those countries, but that's an even deeper issue that I think should be similarly addressed. But research is a means to improving awareness and increasing accessibility to urological care, and to getting the word out there about how to improve health practices. Okay, so that's all I had. Happy to take any suggestions or questions, but thank you for listening.
Great work, Tanisha. Fantastic to see that, see this information, mostly because if you don't put it in numbers, you don't know that it's there, and you have to make it visible to be able to do something about it. I think from my experience over time, part of the challenge has always been that research education or research training is not necessarily a big part of medical training worldwide. And that's been addressed in various ways. Even pre-COVID, the WHO had been involved in setting up, along with MSF, operational research training programs that are entirely YouTube based and things like that. But it's just hard. It's hard to teach yourself how to do research. It's hard to do that, and especially if you don't have good internet and you don't have mentorship. So I think there's a huge learning curve that our colleagues and our trainees and the rest of the globe, really are disadvantaged from. Any thoughts on how that could be addressed within the urologic community? Or, I don't know if any of the urologic societies have research training type courses or content or things like that would be one step along with all the things you mentioned, right? Along with the authorial boards and dedicated sections and things. Would that be one step towards increasing the pipeline? What are your thoughts?
Yeah, I don't know if there are any existing programs. Maybe Dr. Kurtzman might know more about this topic, but I feel like that's a very important tool. And if the AUA or if these larger organizations don't already have it, it would really help. Yeah.
Yeah, I would say sort of in the urology community, there's no prescribed funding available for sending people or providing training and research. I would say that even in the United States, among urology residents, the sort of focus and time given to research-related education is minimal and only really stressed at certain programs. I think what you said, though, Dr. Jayaraman, is kind of exactly the point we were trying to get at with this paper, is just putting the numbers out there to say, like, this is something, this is real, and you know, we probably don't have any magic to change the problem, but in thinking about training programs that people are developing, or relationships that you know, some of us have with programs in the global setting, sort of putting an emphasis on the importance of helping them design and facilitate their own research projects, I view as very important. And for those of you that have been at some of our other talks about the program we're doing here at Utah in urology, one of the big kind of tenets of that program is to support local research. And support is a broad word. I mean, that means both helping come up with sort of research ideas, helping our local partners build databases, and then, you know, in some cases doing research, doing the statistics for them, but in a similar way to how I would mentor a urology resident or a medical student through designing a research project. Just having that be part of our program, I think, is something that is worthwhile for those of us who are doing global health work to make a point of doing. And, you know, one thing that has sort of come out of this work is, again, you know, to get at the issue of getting the research done is one thing, but for those places that are trying to do research, giving them a space to put that work. So the Gold Journal of Urology, which is, I'd say, the second biggest readership from Urologist Journal in the United States, has decided to do a global urology edition next year, where they're going to basically allow for publication of things that might not be interesting to high-income readership, but are interesting to each other.
Yeah, that's fantastic. Dr. Judkins has her hand up. Dr. Judkins is one of our neonatologists, so thanks for making time to be on.
Thank you. I'm one of the neonatologists, as Dr. Jayaraman said, so urology is very far out of my wheelhouse. However, there are commonalities, I think, in the global health space, and I really appreciate your comments about empowering the local communities for research. I'm actually in the process of revising a manuscript. I do work in Nepal and in India, and I think one of the things when we think about capacity building for research is, just as there's not significant amounts of training necessarily in certain LMICs when it comes to research, there's also not, at least in my experience, a lot of time that's allocated to this process. So one of the challenges, at least for me on the neonatal side, and I imagine there's some cross challenges across specialties, is that the projects are a really great idea, but we're working with full-time clinicians who work what we would consider like 3 FTEs of like a clinical job, and they're just hustling. And so the capacity to actually collect data, build a database, have the financial and administrative support required to engage in research, I think is really challenging. And I'm curious, as you go through your process of investigating capacity building for research in urology, if that's come up, and if there are specific countries that you're working with that are willing to sort of expand the capacity in that way.
Yeah, I mean, I think my experience has been the same as yours, Dr. Judkins, about, you know, people are working triple jobs and not finding time necessarily. But we're primarily right now doing work in Rwanda, and Dr. Cohen is going to present one of the qualitative research projects that we're doing with our partners there. And, you know, I think that there are going to be people that have some interest in getting, you know, research done, but it moves certainly a lot slower. And I would say that one of the, aside from sort of training, which I have not really broached that sort of part of it yet, which is the building the training capacity for research. But aside from that, sort of, I think one of the important things that I already said is just having a space to put the research, because it's really hard to be a low-income country provider working, you know, 3 times the amount, interested in research, writing something, and then getting rejected from every journal because it's viewed as not important to the editorial board. And so that's where I really think that those of us that sit on any sort of boards or for journals or publications in the US can actually make a difference, because no one's going to want to do research if you don't have any time and nothing comes of it.
Okay, I have a second part question. That's a second part. It's one of the things that we struggle with too. So one of our recent publications got submitted to a higher powered pediatric journal, and that's great for us. But sometimes open access becomes a challenge when you're talking about actual access to the people who need to read it or who would benefit from reading it, to sort of be inclusive. And then thinking about authorship in a way that is meaningful, like submitting to, like in your case, I don't know very much about Africa, so please forgive my ignorance, but if there's African journals or journals that would be of easier and perhaps not necessarily easier, but perhaps more pertinent access to your colleagues in Africa, and sort of balancing where you submit things. So this comes up a lot for us in Nepal when we talk about even submitting for conferences related to, like, Southern Asia and the neonatal programs that are located in their geographical space versus what we come to understand as high powered or sort of academically more rigorous journals. I'm wondering what your thoughts are about that. And this is like to the whole group.
Yeah, I think I certainly, for my work in Rwanda, encourage a lot of our colleagues to publish in the in some of the African journals. There are just not that many, which is the challenge. So a lot of my work is trauma and EMS related. So publishing in the African Journal of Emergency Medicine is a great place to get information out to the more relevant audience, as opposed to speaking to the, there's this whole concept of like speaking to the Western gaze. And so, who is this information relevant to? And we try to put it out in that, or the Rwandan Medical Journal, or the COSEXA Consortium, College of Surgeons of East Central and Southern Africa, has a journal that is notoriously unreliable, that publishes quarterly. I have sent in and retracted or withdrawn submissions because it just takes like 6 months to get an email back from them, because they don't have the support that a lot of the big journals do, and so I think even the journals themselves are, there's got to be a different model that allows communication across experts without having to rely on the system that exists today. But that's sort of my experience. I'll leave to others to comment. Now, Dr. Rockwell, what's been your experience in Western Africa and with the work that you all have been doing in Ghana?
There's Annals of Plastic Surgery that in the US has been very receptive to ours. It's 10 years ago was the #2 plastic surgery journal in the US, and now I'd say they're probably still #2 or 3. The Ghanaians have found modern plastic surgery. I'm not sure what country of origin that is. They have a small fee, about $300 to publish articles. They will publish everything, I think. And they actually I get invitations to submit articles to them. So and that's the one, the Ghanaians found it, and that's one they like. So fortunately, everything we've tried to do, and I think everything the Ghanaians have done without input from anyone in the US has been accepted, fortunately.
That's fantastic. Ayatemi, I think you're the only African actually on this call today. What have you published as a medical doctor? Have you published any papers, or can you comment on what journals you've been able to publish in? I don't know if she can hear me. Ayatemi is calling in from Lagos. And okay, maybe not. Okay. Well, connection may be an issue there. Great. Well, I think that was a great project, Tanisha. Thank you for opening our eyes on to a variety of different questions, and I think questions that all of our specialties probably need to be thinking about and considering. So I'll turn back over to Dr. Kurtzman.
May I also compliment Tanisha on a very good presentation? You speak extremely well.
Oh, thank you so much. Thanks
Extremely
for letting me
well.
share.
That was very good.
Thanks, Dr. Rockwell.
Yeah, Tanisha is definitely one of the most impressive medical students I think I've ever come across. So we are trying to get her to be a urologist, but there's lots of other specialties on the call here who, who knows where she ends up. She's just trying to figure it out.
I'll make a plug for neonatology. Everyone starts as a baby, you know? You can have all the things, but we all start out as babies. Come over here.
That is
Plastic
true.
surgery.
Thank you.
All right, so I already introduced Dr. Cohen, but Dr. Cohen can take over the screen share, and she's going to be talking about a project, sort of a la Tanisha's study, where we are doing a qualitative research study that's being sort of led and facilitated by our partners in Rwanda. And Zoe has been supporting them in the design of this, and she's going to talk about the project, which is underway. Take it away, Zoe.
Thank you. I'm going to try to do what you did with the presenter view. So let me know. And then you hit switch screens. No guidance on this.
Tanisha, I don't see the little switch screen icon up there, so.
Here, let me try one other thing.
Okay. Because when Tanisha did that, she had a little switch screen.
Yeah.
It was like in the top corner of my screen when I had clicked on presenter view.
That's good, Zoe.
All right, awesome. This is like a modification. This is like a jerry-rigged presenter view. So it's not blurry, is it? Wonderful. Great. Hi, everyone. Thank you for having me today. My name is Zoë Cohen. I'm going to be presenting on the psychosocial and economic burden of benign urologic conditions that require reconstructive surgery in Rwanda. My project is a qualitative thematic analysis, and this project is done in partnership with our colleagues in Rwanda in the Rwandan Urologic Association and the University Teaching Hospital of Kigali. So first, a little bit about me. I'm originally from Boston. I did my medical school at Columbia, and I'm now a fourth-year urology resident at Columbia. This year is a dedicated research year within my residency training program, and I came to be involved in the Center for Global Surgery at the University of Utah by way of my former chief resident, Dr. Drs Kurtzman, who is the fellow in reconstructive urology at the University of Utah and founder of GU Impacts, the Global Urology Initiative and multinational partnership for advancing capacity and training in surgery. That's the only time I'm going to say the full name. And I am the GU Impacts Global Urology Research Scholar at the University of Utah, the first one of hopefully many. I have always been interested in working with underserved populations and in global health, and initially came to pursue a career in medicine because of my interest in public health and improving access to care for vulnerable populations. So I know that some of you may have heard a little bit about GU Impacts when Dr. Kurtzman spoke with you all in March, but just to jog your memories, it's a multi-institutional initiative at the University of Utah, providing need-based support and surgical education to urologists in low and middle income countries. Urologists from across the US provide regular hands-on training and education to local surgeons on a quarterly basis in partner countries. GU Impacts currently has an ongoing program in Rwanda and a new program that will be beginning in 2025 in Cambodia. GU Impacts is dedicated to improving patient access to GU surgery by transferring surgical knowledge and skills across borders, enhancing access to standard of care techniques and technology, and supporting local provider-driven research. The priority of the organization is to enact change that's measurable, safe, transferable, and sustainable, with an ultimate goal of establishing and supporting the success of local regional fellowship training programs in subspecialty urology in these locations where they don't have any and where subspecialty care is very much needed. So the current subspecialty focus of GU Impacts in Rwanda, in Cambodia, is reconstructive urology. This focus was determined based on patient and provider need and feasibility, which we gleaned from the needs assessment that Dr. Kurtzman did last year at each of our partner sites. Before going any further, I just want to give a little bit of background on reconstructive urology globally. Reconstructive urology focuses on restoring function to the urinary and reproductive systems after they've been affected by injury, disease, or congenital anomalies. When left untreated or when inappropriately managed, these conditions can progress to devastating physical and psychosocial outcomes, which include kidney failure, infection, recurrent hospitalizations, infertility, social stigmatization, and even death. In low and middle income country settings, injury and disease of the urinary tract are common, but access to treatment for these conditions is scarce due to a lack of trained providers. Currently, much attention is given to global surgery initiatives focused on female fistula disease and oral maxillofacial reconstructive surgeries. For example, Doctors Without Borders performs surgeries around the world and indicates on their website that the surgeries fall under these 4 categories. Within specialized reconstructive surgery, there are examples of surgical initiatives around the world implemented by MSF for women with fistula and for children with facial deformities. We suspect that reconstructive urology issues are similarly devastating to patients around the world and present a host of psychosocial, functional, and financial issues. However, this isn't really reflected in the availability of funding or in the availability of providers of urologic surgery globally. In one study conducted in 2016, the authors conducted a database search of all the registered charitable organizations in 5 high-income nations: the US, the UK, Canada, Australia, and New Zealand. And they were identifying all organizations committed exclusively to surgery in low and middle income countries. What they found was that the overall spendage across groups was $3.1 billion between 2007 and 2013. And the overwhelming large majority of charitable organizations and funding went to programs that were focused on ophthalmology and cleft lip surgery. At the time, only one organization dedicated to urology was identified, and in total, only about 0.1% of that $3.1 billion spent on global surgery by these organizations went to urology-specific programming. So our hypothesis is that the limited funding and interest in global urology work is in part due to low visibility of the burden of living with these urologic diseases in low and middle income countries. As a result, in partnership with our colleagues in Rwanda, in the Rwandan Urologic Association and the University Teaching Hospital of Kigali, we have together set out to design a research project to study this issue. Our research project specifically aims to assess the psychosocial and economic burden of living with these common benign urologic conditions that require reconstructive surgery in low and middle income country settings, and specifically for this project, examining the effects of these conditions in Rwanda. Our goals are to report on the burden of disease, shed light on the importance of funding global reconstructive urology work, justify and promote further research to study common and devastating urologic pathologies in low and middle income countries, such as GU tuberculosis, and to encourage local health administrations to support reconstructive urology as a subspecialty and provide time and funding to build local programs to address this need. Significant emphasis has historically been placed on initiatives designed to increase surgical capacity to treat pediatric conditions and malignancies as well in these settings, while minimal attention has been given to efforts that address benign conditions that require reconstructive surgery in adulthood. These conditions are relatively common in low and middle income country populations and can be very debilitating to patients and their families. We suspect that at least this is in part due to the burden of these conditions never having been studied, that they're not getting the attention that they deserve. There's a lack of information about what it means to live with such a condition in these settings, and an assumption that since the conditions are benign, the burden must be minimal. So when we refer to benign urologic diseases that require reconstruction, we're talking about urethral stricture disease, pelvic fracture, urethral injury, GUTB, and congenital anomalies of the urinary tract not addressed in childhood. So that includes hypospadias, intersex, and GU exstrophy. These diseases are often associated with congenital or acquired urethral stricture or a disruption of the normal path of the urethra, which can lead to the requiring of a chronic indwelling Foley catheter in order to empty one's bladder, and it can also affect one's fertility. Understandably, the impact of these conditions across multiple domains of life, if left untreated, can be catastrophic even in a high-income country setting, but we hypothesize could also carry greater load in the low-income setting, since these conditions require access to resources that are expensive and challenging to obtain. They can also limit a patient's ability to participate in normal activities because of stigma, impact on potential fertility, or sexual activity, and or ability to effectively contribute to the workforce. According to a study published in BJUI, patients living in high-income countries with urethral stricture disease often report a significant decline in their quality of life in the setting of the emotional burden of ongoing treatment and symptom management. These patients often experience significant psychological distress, including anxiety and depression. While currently unstudied, social stigma associated with urologic conditions can lead to social isolation, further impacting patients' mental health and well-being. The disease can adversely affect sexual function and intimacy, which can lead to strained relationships with partners, and this can further exacerbate those feelings of isolation and reduce self-esteem. The conditions can also affect families of patients with the condition, as many become caretakers for the patient. And in a low or middle income country setting where there's comparably limited access to social and mental health services, it's possible the psychosocial burden is, that much greater. At present, the data on the prevalence of benign GU disease is limited in low and middle income country settings because in part due to not having an electronic medical record and decreased accessibility of patient data or inconsistent accessibility. Anecdotally, though, the epidemiologic burden of conditions that require urologic reconstruction is relatively high in these settings, and the ability to provide surgical care, as we've mentioned, is limited. In 2023, one study at a tertiary hospital in southeastern Nigeria found that over a 3-year period, urethral stricture disease made up 9.3% of all urologic disease presentations. A sub-Saharan tertiary care center in Zomba, Malawi, found a similar portion of patients presenting with urethral stricture pathology. Patients seen in these regions tend to have lengthy or recurrent strictures, making them poor candidates for repeated dilations and better served with urethroplasty. Surgical management with a urethroplasty requires local practitioners to obtain specialized training with fellowship training in reconstructive urology, which is currently not accessible to most providers working in low and middle income countries. Therefore, patients' options for definitive management of these conditions is extremely limited, and patients will often require a chronic indwelling catheter. While treating the conditions has its own costs to the healthcare system and to the patient, especially in settings without a public healthcare system, there are additional opportunity costs associated with waiting to definitively manage these conditions by way of lost productivity of patients who are unable to work due to catheters, limited mobility, stigmatization, having to go to the hospital, make appointments, etc. In low and middle income countries where men traditionally provide the majority of household income and where government programs for financial assistance are limited, we suspect that effect of urethral stricture disease and injury, a condition that predominantly affects middle-aged men, on economic productivity is significant, but this is yet to be studied or quantified. So kind of getting into a little bit more specifics of our study. For our study, we've obtained local IRB approval. Recruitment of participants happens in collaboration with our colleagues in Kigali. Patients who are seeking care for these reconstructive urology issues will be offered the opportunity to participate in the study. Participants must be living with the urological condition for at least 6 months. We know from our previous work that the average wait time for repair of a urethral disruption in Rwanda is 41 months, which is 3.4 years. So it's likely that there will be ample numbers of potential participants who meet that greater than 6 months with the condition criteria. Patients will be compensated for their time with a small monetary sum of approximately $10 per interview. With respect to our methods, we have not yet begun to collect data, but we've mapped out our project and are ready to go to Rwanda in 2 weeks to begin enrolling our first patient and conducting our first interviews. Consent will be obtained verbally at the beginning of the interview, and a written consent will also be completed by participants. Written consents will include a statement on confidentiality and a disclosure about the risk of possible emotional distress while being interviewed about personal experiences as an underrepresented group in medicine. So to mitigate this risk, participants will be reminded that their participation is voluntary and that they can end the interview, skip questions, or withdraw at any time. The interviewer will be a urology resident, Dr. Mutoni, in Rwanda. Interviews will be conducted in the patient's native language, Kinyarwanda, and data is going to be stored on a password-protected device. Information from interviews will be de-identified and recorded in a password-protected data storage application on a password-protected and encrypted computer. And then only those involved with the conduct of the study will be permitted to access participant information. Identifying information is going to be stored separately from interview transcripts and is not going to be used in any part of the publication resulting from the study. Participants are going to have the opportunity to review and modify their transcripts of their respective interviews if they want to, and any information with a high potential to identify patients is going to be excluded from any published manuscript. Because of the need for an accurate transcript of interviews for analysis, the interviews are going to be audio recorded. Audio recordings won't have any names attached to them when they're stored for transcription, translation, and review purposes. And then they'll be destroyed once all the data analysis for the study has been complete. Participating patients will consent to have their clinical charts and data reviewed for use in conjunction with their interview responses. The clinical information that we're going to extract includes the history of their urologic condition, the details of any previous surgeries, records of previous hospital admissions or emergency room visits, the intraoperative details of their definitive surgical repair, if applicable, and then their postoperative courses, if applicable. The data will be de-identified and recorded, again, on a password-protected data storage application, on a password-protected and encrypted computer, and then only people who are involved in the study are going to be able to access that information. We anticipate that the project will last for a year, from October 1 until 2024 until December 31st, 2025, and we're targeting 30 participants. Ideally 10 from each category of the reconstructive urology categories that I mentioned earlier: urethral injury, GUTB, and congenital urological conditions. We have been working in collaboration with multiple people at the University of Utah, including Lindsay Hunt, Dr. Melissa Watt in the Department of Population and Health Sciences, and research analyst Aparna Mengadu to develop a qualitative interview guide. Adapting a qualitative interview guide that was created by Dr. Watt several years ago for her study in which they interviewed women in Tanzania with fistula, we have produced a qualitative interview guide for our study designed to capture the breadth and depth of the impact of these urological conditions on our patients' lives. So all interviews begin with obtaining verbal consent from the participant and an opportunity for them to ask questions before we begin. The qualitative interview guide has multiple sections to catalog the diverse experiences of patients and to allow them to tell their stories. The sections include questions aimed at understanding their experience developing the condition, living with the condition, and their thoughts and feelings around surgical repair. So here are some examples of the open-ended questions within each section and the effects of these conditions on the various domains of life we aim to learn about from participants. So for experience of developing the urologic condition, we'll ask them to tell us about their condition, when they realized they had a serious condition, their experience seeking help before their diagnosis, experiences with the healthcare system, how the condition has impacted their life in the last year. For each of the questions, we have follow-up questions to probe for specifics. And we include questions aimed at understanding the patient's relationships with friends and family, their romantic relationships. We ask them to tell us about their religion, how their condition has impacted their religious activities or involvement in religion. Patients have opportunities to speak about their mental health, experiences with stigma, and sense of identity and manhood as it pertains to their condition. and they'll be asked to tell us about how the urological condition has impacted them physically and financially. We ask patients to think about the future, what they're hopeful for, what they're worried about, any questions that they have. And then finally, we conclude by allowing them an opportunity to share any information that they haven't yet had an opportunity to share or that they want to emphasize. We also have put together a post-interview survey to gather some information on a few targeted quantitative data points. Specifically, we are curious to know effects on romantic relationships and if their benign GU condition has prevented them from marrying or having children. We also wish to quantify in some capacity the opportunity cost associated with lost work hours and work productivity due to the need to attend appointments, be hospitalized, or just being unable to work because of the state of their urologic condition. And we're going to provide this at the end of the interview to avoid risk of introducing bias based on the patient answering possibly sensitive questions about their monthly income, inability to work, or relationship status. Our data processing and analysis will first require a review of the recorded data and transcription with, in all likelihood, translation if the interviews are in the local language as we expect them to be. Our team includes qualitative researchers at the University of Utah to help guide the methodology of thematic analysis extraction from the interviews. And then, as mentioned, we have that quantitative data to examine from the post-survey. So some anticipated challenges, we'll be working with a local translator to ensure that scripts are accurate. However, due to cultural or linguistic differences, there's always a possibility that data can be misinterpreted during the translation process. This is a part of our data collection process to which we're going to have to be especially intentional and attentive. If any of you have had experiences with this kind of with transcription, translation, we welcome any suggestions or things to look out for. And then very recently, we've learned about an outbreak of Marburg virus in Rwanda, which between yesterday and today, we've learned this is going to require our postponing of this current workshop, which was previously planned for October 12 to 19. So major bummer, but we're still going to do it. And we're still very excited about the work. Just means we have all the more time to prepare. And these are just a couple of the challenges that we've hit so far on the road. Before I conclude, I just wanted to say a quick thank you to Dr. Kurtzman for being my research mentor, helping me develop this project each step of the way, teaching me, and for making my first real venture into research such a rewarding one. Dr. Myers for also welcoming me to the GU Impacts team, Dr. J. Araman and Anna Darelli Anderson for establishing the University of Utah Global Urology Research Scholar Program. To Dr. Muhanwena Mana, who's our close colleague in Rwanda, who's been instrumental in our partnering on these initiatives in Rwanda. You guys have all made it possible for me to contribute to such meaningful work, and I'm already so grateful to you, even though it feels like we're kind of still at the beginning stages of our project. And then a big thank you to Dr. Watt, Aparna, and Lindsay for helping us design the qualitative study and helping with our qualitative interview guide for the thematic analysis. So I look forward to updating you all as the project gets underway, hopefully, in the coming months. Happy to take any questions. Thanks for your time.
Very cool. Thank you so much. It was just occurring to me that this has so many applications, this sort of way of thinking has so many applications, right? Just from like one of our other colleagues is a colorectal surgeon who's working on this colorectal fellowship in Ghana. And it's like, oh, ostomy care. You could use the same model to kind of think about looking at ostomy at patients, having colorectal conditions and ostomy care and stuff. So there's just so much that that you can learn from this way of thinking. And it's just very different for us surgeons. Like, we're not used to thinking about these kinds of things in this way. And so it's great to recognize, great to recognize the gaps in our knowledge and our perspective and work with colleagues across different disciplines. So very cool. Thoughts from anybody else?
I have a question for Dr. Cohen. Thank you for this presentation. It was really great. And I'm always very curious with the qualitative research side. So my question is, and I might be wrong, but you said you are going to enroll 30 patients for this study. So
That's all.
have you considered like cultural side of it, like if they will be comfortable to get enrolled in that, and like, and also the second part of it is that I did a qualitative research in my master's, and I did it with refugees, and they were not uh, happy being recorded. So if they are not okay with that, are you going to still include them, or what is your process for that then? Thank you.
Thank you so much. That is a great question. And, in terms of the way that we've designed it, how we ideally want it to play out, ideally, we want, patients to be willing to participate and share their experiences. We're in no way pushing anybody to share their experiences. So we'll have to see a little bit how patients will respond, and if they'll have those kinds of reservations about recording. If that's like consistent, then we may have to rethink that. But yeah, that's definitely something to consider, and maybe have like some kind of contingency plan for, just to make sure that we can make the most of our time there and our time with patients, if they're going to have those kinds of reservations about being recorded, especially. With respect to sharing about their experiences, they also can choose to answer the parts that they're comfortable with, and the parts that they are not comfortable with, they don't have to respond to any of it. We'll remind them of that. And it just might be that we end up having a paucity of responses in particularly sensitive categories. I hope that's not the case. I hope we find a way for people to be comfortable sharing it. But if not, then that will be a part of the learning experience too. And this is going to be a longitudinal relationship with this is a longitudinal relationship with our partners in Rwanda. So hopefully we'll have multiple touch points with the patients as well. And so I will keep you posted, but definitely something for Dr. Kurtzman and I to discuss with our team. Thank you so much.
No, thank you. I'm really excited for that.
Thanks. Me too.
A couple of questions. Do you already have a list of patients that you're going to recruit from already in place? And the second question is, how much time do you think you will stay there to do this job, and how many patients you're supposed to recruit for the study?
Yeah, I'll answer those questions, Dr. Smythe. So yes and no, I would say the answer to, do we have patients that we're going to recruit? Our partners in Kigali have a list of patients that are, meet eligibility criteria that we've not yet talked to about consenting for the actual study. The initial plan up until really yesterday was that we were going in 2 weeks, and we were going to be consenting. Really, our partners locally are going to be in charge of consenting and doing the interviews with the patients. And so they're kind of running the show on that. But we were going to be there to sort of support it, see how things went, get feedback in real time. We don't necessarily have to be there and not to have these interviews conducted. That's how this study is designed. But, to get it going, the goal was for us to be there in its first days of speaking with patients as sort of a pilot study. Unfortunately, because of this virus, we are no longer going to Rwanda in 2 weeks, and we'll have to revisit when we can go. But we may just take the stance with our partners that they just get it going in our absence. And then in terms of numbers of patients to recruit, after consulting with some people or experts in this sort of field, our target number is 30 patients. Based on the number of patients that they see with these urologic conditions, I think our understanding of being able to recruit 10 patients with urethral stricture disease and 10 patients with congenital anomalies is going to be very easy. The one group that may be a little bit more challenging to recruit is the genitourinary tuberculosis group. So we'll have to see sort of who those patients are. The good thing the thing about Rwanda that makes this a very feasible study is that there are only 13 practicing urologists in the entire country, all of whom are members of the Urologic Association, and many of whom are to be involved in this project. So it's kind of recruitment from all over the place. Does anyone have any other questions? If not, I think.
Just a quick follow-up on that. I know you have some pediatric background, so what's the percentage of the patients that you expect to recruit with the pediatric, or are they involved at all?
So the pediatric, I'm sort of putting in quotes, group that we're intending to recruit are patients that have some sort of congenital anomaly that they've aged into adulthood with. Our target is 10 patients from that group. I can tell you that within the last year, in just the clinics that we've helped provide during our workshops, we've come across about 5 of those patients in the last 6 months. We are hopeful that these patients are willing to engage and talk about their conditions. And we've been very lucky that the person that we've been put in touch with, who will be doing hopefully most of our transcription and translation and some element of patient recruitment, has done other projects that are similar with other groups. And he works in the urology clinic as well. So that's a helpful point. But I think everyone's probably heading out. So I just wanted to say thank you, Dr. Jayaraman, if you're still on. And thank you, Anna and Liz, for putting on this every week. And thank you, Zoe and Tanisha, for everything you guys have done and are working on. And super excited to have you guys speak again, Zoe in particular, when we get this off the ground and we have some preliminary sort of data and feedback to report. And if anyone has any feedback, we would love to hear it. So feel free to email me. It's Jane Kurtzman. I can put it in the chat. But thanks again, and I hope everyone has a great rest of their day.
Thank you.